thank you so much for your time this evening. And we're just going to spend a little bit of time going over what blood results mean. We've all had our annual physicals or gone to the doctor with a particular thing in complaints. Maybe something just doesn't feel quite right and they'll order some blood tests. So we've probably heard these, seen these plenty of times. And I just wanted to take some time to walk through. And as we touched on earlier, with as far as it pertains to clinical research, I did not structure this presentation with that in mind, but I will touch on that because I think that is a very important part. Because clinical research just call out what we call abnormal, which doesn't necessarily mean there's something wrong. So I think that's a good way to marry those two. And what do your lab results mean, and what do they mean for you? Next slide, please. So, of course, when we order tests, what do they test? The majority of the samples being tested are blood samples, and it's about 70%. And why? Because that's most easily accessed and can reflect many different functions in the body, as well as the status of the body, just from the blood. Right. Next up, of course, we've all had to give a urine sample, sometimes unexpectedly, sometimes a lot compared to what we would normally have to give up. So that's the next biggest bucket of about 20% of all samples. And again, this is easiest to collect. We've all done a dipstick at your doctor's office, for some very high level testing. Usually for us women, that's usually a pregnancy dipstick, just to do a quick check to see. Most of the time, whatever those tests are with a dipstick, there's usually going to have to be additional follow-up testing, be it blood or culture or tissue or whatever. And then lastly, which I think will be touched on next week, is some of these biopsies or other tissues that are being tested for other things. And I would say, again, usually what the doctors may see with the blood or the urine may require other tissues or other fluids to be tested. Okay, of course, I think the one here for us especially would be, unfortunately or fortunately, Cologuard is one of the tests that has been used, and that's an example of where you might need to take your doctor or gather a sample that can be tested further. Next slide, please. So as always, usually your doctor will tell you, okay, we're going to schedule. And I think mostly for our physicals, which are probably planned, right? We normally usually try to give the blood work before the appointment so your doctor can have, or your healthcare provider can get the results back and then be able to look at them and walk you through and talk through it. So, of course, we've heard you need to do a fasting time, or maybe some tests can be done non-fasting. It just depends on the test. It can usually be 9 to 12 hours, avoiding any food and only drinking water. As for myself, I always have to remind myself during that time, do not neglect the water because you can very easily become dehydrated as well, which will make other things more difficult. Of course, get plenty of sleep. I think a lot of times, I know I'm a little nervous when I'm going for this. I'm freezing, I'm in a hurry, and it's just all these other things that can make this a lot less enjoyable experience. The blood tests that require fasting are your liver function test, or your cholesterol test, triglycerides, blood glucose test, your metabolic panel, or your cholesterol test. So they're very specific ones that will require you to fast, and some others that do not. If you're not required to fast, still consider avoiding alcohol or fatty or rich foods. And if you can't, have a small meal 1 to 2 hours before your draw. Big importance, you must, as your doctors or your healthcare professionals are ordering these tests, right? You want to make sure that you follow their specific instructions for your specific situation. And I think the biggest thing to call out there is that we all have some medications that we take daily. Some may have to be taken before you take your blood draw, or different times during the day, or you may have to take it with food. And so there's some other kind of considerations that you just need to talk through that with your doctor to get the proper instructions. Okay. All right. Next slide, please. And I hope everyone can see the slides. So we want to make sure. Okay. All right. Let's see. So as we get to the facility, and of course, we're getting our blood drawn, they're going to have to make sure you can usually do it seated or standing. Of course, confirm our identity, all the same things when we're getting blood drawn. We've all had it done. Now, one thing I like to call out is the number of vials and the type of vials that will be used depends on what your doctor has ordered. Um, and then after, of course, just normal when you've given blood or you've maybe been a little have had to fast and so you haven't eaten for a while, just some considerations. Maybe you may feel a little dizzy, so or sick, take a little snack once you've given your draw, and then of course just kind of rest and just kind of refresh yourself after that day. All right, next slide, please. So once the samples are received, as I said, depending on the tests that have been ordered, they will be tested. And now that we have electronic medical records, or a lot of practices have portals, usually I try not to look, but I do like that I can see some of the results a little bit more quickly. And the doctors will, of course, see it and usually schedule you for a meeting to come back in to go over a visit to go over it. And so what do these mean? So those results come back in terms of lab reference ranges, or you're based on lab reference ranges. So we've all had a Quest lab or LabCorp or some of these other labs, and their tests are run and they are standardized, meaning every place that that lab runs, they do it the same way. And so those results, they have ranges and expectations for their particular test. It may vary slightly depending on where it was, but they still have a range that they have compiled for their facility that tells them what the ranges will be. And I think, of course, these tests showed levels of various components in our blood, and abnormal results or out abnormal ranges can indicate a health problem, but not necessarily. And this is one of the things, as I mentioned before, as we were talking about clinical trials, and as well as us as a people in different groups, age groups, racial groups, of course, males versus females. Some of these labs, they're going to be, our levels are going to be different. And so the reference ranges or lab ranges are gathered based on testing a whole bunch of people in particular groups to compare what their results are. So that's how they come up with like an average or an expected range for certain ones. And sometimes, as Lisa touched on, when we're talking about clinical trials, some of these may be abnormal or out of range. And sometimes that's what we're looking for because of a particular disease state that might be being tested. So that is a whole nother conversation we'll have. But I think it's important to point out, especially with this group, that there's a lot of nuances and there are differences in how our ranges look as women, as people of color. And so they have various ones that they look at. Of course, children versus adults, or even adolescents versus elderly. Your next slide, please. So you've given blood, you've gone to the doctor, you've gotten all the results back. One of the most common ones that you will see is your complete blood count. This measures the different types of cells in the blood. It is very common and is always part of your routine, usually a part of your routine lab work. There's many things that this can tell, and this is usually probably one of the first steps that your healthcare provider will use, because it can then point them to different areas that they may need to do further testing. So you've heard white blood cells, which are indicative of infection. So there's certain ranges because you want them there kind of to be that's normal for them to circulate. But of course, when you have spikes or higher ranges, it's usually indicative of an infection. Red blood cells, those are affected, especially in our community, with people with sickle cell, because those cells are abnormally shaped and causes us issues with carrying oxygen. So some of those are indicative of people of color. Hemoglobin, platelets, hematocrit, all of these other ones you've heard, and they're just various ways to look at the blood, and this is compiled from blood samples as well. Next slide. So as I said, sometimes the complete blood count, or CBC, is one of the first tests that your provider may perform. And depending on what they see, they may want to do a CBC with differential. And this is just some of those more specific blood cells that they're looking for. And specifically, these are white blood cells. So there's a whole lot of information that can be garnered from this. And so depending on what your doctor sees or what you might be complaining of or feeling, they may order these tests proactively as well, just to look at a total picture for a complete blood count with differential.
I have a question, Marshika. Are you going to mention anything with reference to hematocrit, globin about iron and iron deficiency or anything like that, or talk to us about that?
Not for this one, but I'd love to. I think we should because I think there's so much that we can talk about with that and kind of the synergies with all the other um uh items in the blood that kind of work with it. So I didn't go into too much detail about that with this one, but I think we should definitely do that as well.
Okay. Just if you would go back to the previous slide just for 1 second.
Okay. Taps. Thank you. Uh-huh.
So on this, just when we're talking about iron, would you point out specifically, those that are important to us in that, I guess, hematocrit and hemoglobin?
Yes, those are probably two. Because again, as I mentioned, sometimes like you eat certain things before you take the test, it can affect that. But that is a good call out. The hematocrit, your white blood cells, red blood cells, and platelets. Platelets also are very important. I'll touch on that later with INR. That's very important as well. So I think that's a good call out. And yes, your hematocrit, I've seen it for personally, it can vary depending on what I've eaten before I take the test, right? Or, it is, again, you may be abnormal, but for my husband who works out a lot, some of those things are affected by that. So I think, thank you for that call out. And I definitely appreciate that. And I think it's a whole nother conversation to talk about the iron deficiencies, vitamin D, and those kinds of things that we struggle with as a community.
So I
Okay.
do have another, I have a question.
Uh-huh.
This is listed as the normal range, but is there a range that's more particular to say women versus men or different ethnicities?
Absolutely. Although, again, like when you get your results, usually, like I said, one of the first things they do is ask you, of course, they look at your ID and make sure, you're a female, this age group, race. And so they run your test, and then what your results are, they compare them against the group that you're in. So, as I said, sometimes what might be normal for a person of color, it won't look like that for other groups. For us women, of course, these are iron, as Lisa mentioned. Of course, those levels can fluctuate depending on if we're premenopausal or just pregnant, or there's so many different variables. But yes, those normal ranges, they are normal. And I hate to use that word, but they are corrected based on those particular groups. Okay. Thank you. Next slide. So as we talked about, I know a lot of times you probably noticed this one when you're about to give blood. This INR, which is International Normalized Ratio, but you'll hear INR more often, is it looks like how well our blood clots. There are some diseases, and some of them are genetic, such as hemophilia, where you have issues where your blood does not clot, right? They need to look at this sometimes before you may give or have a procedure. They may check this to make sure that your blood is going to clot as it needs to, so you don't have hemorrhaging. The results are reported and calculated based on a prothrombin time. So you probably had your fingers stuck, and they take a little drop, and then it measures, they drop it in a solution, and it just measures how long it takes that blood to clot, right? And that's really what they're looking at. We've all probably known someone, or hopefully have only not have had to be on it chronically, but warfarin or Coumadin, which a lot of people that I've known that maybe have lupus or some other diseases, they that's a part of their life, just to make sure they don't have clots. Or I had someone, she was having strokes and wasn't sure why. The doctor unfortunately had to put her on a blood thinner just to kind of keep that at bay until they could figure out why she was having strokes. So there's many different reasons that people are on blood thinners. But again, if your blood does not clot properly, you are very at much risk for hemorrhaging. And so one of the things that, especially I know, if you're on Coumadin or a blood thinner, this test is going to be done pretty often to make sure that your levels are correct. Because we don't, again, the higher the INR, the thinner the blood is, or the less clotting that it's doing. And we don't necessarily want that. And so there's a lot of close monitoring with this testing for people that are on these drugs. And we do have warfarin has been the standard, but there's newer classes of drugs I will mention that are on there. So always talk to your doctor about what are some of your other options that might be a little bit easier to manage than Coumadin. All right. Next slide, please.
Can I add something?
Sure.
Just wanted to add about the diet and vitamin K intake,
Uh-huh.
the leafy green, and medications, they interact with the INR levels as well. So,
Good
all,
call.
yeah.
Thank you. I think we can have a whole 45 minutes talking about kind of some of the foods that do interact with these, just as you said. So that's a great call out. Thank you so much for that. All right. Next slide, please. Electrolyte panels. So electrolyte panels, you maybe heard basic metabolic panel. This is a lot of these are very basic parts of your blood that are important. Usually you'll see it as a complete metabolic panel, so a CMP rather than a BMP, which is just nomenclature. And this just means it measures all of the electrolytes above plus your liver function test, which we'll talk about what those look like. And a lot of these sodium, potassium, chloride, all of these, they're very important because they're can tell you things like, again, like I mentioned about your hydration and nutrition status. Of course, we've all heard the sodium and potassium and those, and as far as our kidney function. And this acid-base balance, which is chemistry, of course, but if that is off with these electrolytes, you're going to have issues. So this is a very delicate balance. It may vary at times, but this is a way that doctors can get a good view into how you're doing. And again, depending on certain disease states, these levels will vary. They may be, as we say, out of whack for a bit. But these are, or if they're higher or too low, these are kind of things that we look at. Okay. And as I mentioned, the liver function test, they just measure, of course, enzymes and proteins in our blood that the liver controls. And so these are very focused on, showing things like inflammation. So like cirrhosis, if you've got liver damage, blockages, and definitely in gallstones, which we know that can happen. Specifically, what are they looking at? These ALT, these letters that you'll see, bilirubin. We've all heard, babies are born a bit early, and their livers aren't quite developed, and they'll have too much of that and have that yellow. That's the jaundice, the bilirubin. Some of the other ones, the albumin, again, high protein, that can be a sign of an injury. So looking at these blood, say for instance, I think boxers is a good example. They get hit in the kidney and they may draw their blood after. Some of these are going to show that because I'm sorry, their liver from the fighting, right, is an example, and that damage or that injury to their liver can be seen with some of these blood draws. So that's just a bird's eye, I guess, initial look into your liver. As we talked about, if there's some issues that they see, sometimes you may have to have a biopsy, which is that other group that we talked about, samples being tissue.
Quick question for you.
Uh-huh.
I've seen these acronyms and abbreviations on my report, but I've never heard anyone actually pronounce them. Can you read what the stands for us, please?
Monica, you're oh my goodness, you're gonna test my Southern. Okay. Alanine aminotransferase is the ALT. Aspartate transaminase is AST. Alkaline phosphatase is ALP. Albumin, TP, of course, total protein. As I said, bilirubin. GGT is gamma glutamyl transferase. And then LDH is lactate dehydrogenase.
Thank you.
Uh-huh. Say those 4 times in the row and see how they come out. But thank you for that. That's a very good point. And you'll probably ALT, AST, of course, the clinicians, that's what they refer to as, like this, the back of their hand. All right. Blood glucose, of course, diabetics, women, we're pregnant and you have gestational diabetes. This blood glucose is a measure of the amount of sugar in the blood. In our community, we've referred to diabetes as the sugar for generations. But it usually, of course, if you're diabetic, you got your finger prick and you've got the machine. But as a part of a standard panel, they will, from drawing your blood, they can look at it. And one thing I want to call out, this is most definitely one of those tests that if you've been asked to fast for a certain period of time, you really want to do that. Although we now know if you haven't fasted, and another test that I've underlined here because I think it's very important that we be aware of what those levels look like, your hemoglobin A1C. So that A1C is a test over a 2 to 3 month period. They can draw your blood today, and based on the levels they see at that, they can tell pretty much what your blood sugar usually is in across that time period. And so it gives them, like I said, if you take it that morning, you may have forgotten and you had a midnight snack, or you fasted 7 hours and not 8. It just is an example. So it may be skewed a little bit, but that A1C is really going to tell your doctor clearly how your blood sugars are averaging over a time period. So it's not an acute or immediate change, increase, or dip, but they can see it over a 2 to 3 month period. That is one that we really want to look at and kind of watch, because that is a good indication of how your blood sugar is doing, as well as healthcare providers using it as a predictor of your risk factor for diabetes. Next slide. So next up, our cholesterol. There's a mix of cholesterol, but the test that you look at, so you want to look at your LDL, low density lipoprotein. That's considered to be the bad cholesterol, and because too much of that will definitely it will lead to heart disease. Cholesterol is not a bad thing. It is a building block for many different needed substances in our bodies. A lot, really, hormones is a big one, right? So high density lipoprotein is considered the good cholesterol. You need it. Too much of that, it's kind of like a yin and a yang. And so you want there's a ratio that is expected and that's healthy, right? So you have to have enough of your HDL, which is the good cholesterol, and then not too much of the low, but the low is still going to be there. So that's one thing to keep in mind. And then triglycerides, which is a type of cholesterol that the body uses for energy, right? Too much of that, it's not a good thing either. So usually when you have this test done, it's looking at the total cholesterol, which is all three of these. And sometimes they may be a little off, but they look at the ratio of the three, and within certain ranges, you're so fine. Also, I'd like to call out a lot of our community. We do tend to suffer from high cholesterol, various reasons, probably the way some of the foods that we eat. But to be fair, there are known to be some genetic components. So some people, no matter what, they're vegetarian and they have high cholesterol, right? So it's genetic. Some families, they tend to have higher cholesterol in the families, no matter how they eat. And so they have to just be even more diligent in watching it.
I have a question, another question here. Is it true, or I'm just trying to figure out, when they talk about the normal range, has that number varied over the years? If so, why? Or if not, then maybe that's something someone made up, but has it always been normal is less than 200, or had it been something else?
You know what? That's a good question, and I will have to follow up offline. I know typically when we're looking at labs that do these tests, they have these ranges. They have dates, right? So of course, you have a lab. Every so often, you have to go in and calibrate, and just make sure your levels are what they are. And so I'm sure there is a pooling update here and there, but that's a very good call out, and I will definitely look into that, and we can add that and provide that offline.
I'm going to ask if there is any providers are there that are on that may have an answer if they want to call it out later, if anybody's on the line.
So, Lisa, far as I know, it's always been the criteria, but the American Heart Association, I think, is the one that you can go and look at what's healthy heart. But as far as my understanding, it's, as long as I've been a practitioner, it's always been like that. But it might be something different. But that's what I know.
Thank you, Cynthia.
And the one thing, I'm not going to address the numbers. As we are getting smarter, we are understanding that in addition to these cholesterol tests and these markers, they now, and it may not be on here, the alipoprotein is another test that is done that shows proteins on the lipid, that depending on your practitioner, they may order that depending upon what they've seen, what symptoms you may have, and other things, and may order an alipoprotein test. And there's specific ones that will be identified and may show someone at higher risk for heart disease. But I don't, that's a whole different,
Yeah.
that's a deeper level than this, but it made me think of that when you said, are these ranges the same? There's just additional tests that may help with understanding of cholesterol.
And that's absolutely right, Lisa, because for like my husband, he has a family history. Even my youngest daughter, cholesterol could be high, but they do
Yep.
do different tests just to see what is the risk of heart disease. And so that's why it's important to go back to not only the lab, but really get down and get a family history of what happens in your family.
Yes, thank you, Cynthia. I totally agree. And I think I wrote a note. We'll make, maybe I can add that offline, and we can put about the alipoprotein, or if you want, if you know, for the diagnostic testing or further. I think we should definitely dig into that, because Cynthia, as you mentioned again, it could be familiar, and you're not an quote unquote unhealthy person, but for you, your norm, you've got these higher levels of cholesterol.
Yeah, I just wanted to add, great point, Cynthia and Marshika, you're doing such a wonderful job. Just to mention that you reiterated that sometimes these levels are different in men versus women. So make sure you just reference those levels and when it comes to those different sexes.
Yep. And I think further, as I said, the reference ranges, right? They're different, but not, I dare say, not overly different. There's a standardization somewhat across the labs. The units may vary, but you know, again, they calculate them in the proper unit based on their particular lab. So just want to make that. Thank you all. Thank you both for that. I appreciate that.
Did
Next
everybody
slide.
understand what she
Oh.
just said in terms of that calculation?
No.
Okay, I didn't think.
Okay. Okay, so stick a pin in that, because if you see when we get to the next slide, then I can point out what I meant. I think the next slide will
Okay.
have those units, so you can. Oh, well, maybe not. Let's go. Yes, there are units here. So the next one, a lot of people have probably heard of your thyroid, right? A lot of times, the thyroid function test. I have known from my own personal experience that sometimes I've had to fight to get this done. Because I've had certain things that I was like, I need you to check this or check that. And, you know, there's certain levels, as Lisa pointed out with the alipoprotein, you can do the first level of testing, but there's more detailed testing that will give them a better picture. So this is one of those as an example, because your thyroid function test, the main test is the thyroid stimulating hormone, right? And this tells your thyroid to produce the hormones, to produce thyroid hormone. If it's high, it means the thyroid isn't making enough. Low can mean the thyroid is overactive and making too much. So a normal range is that 0.4 mils. That those are the units that we were talking about. And when I say the units, depending on the lab that you've had the test done at, those units may vary a little in how they measure. So that's what I wanted to call out in those units, but they normalize them. And what I mean by normalize is, even though it may be a certain unit or a certain amount here based on these units, when you look at that result, they've told you what the range should be for normal for that unit. You may go to a different lab and have the same test done. If that has a different unit, it may look different, but they will tell you what the normal is for their lab's unit measure. That's what we were saying about the unit, and depends on the lab that does it. So what if they say 0.8 nanograms, right, per deciliter, which is what that means. That's what, when if yours came back in micrograms per liter, that's not the same thing, right? So they're going to have to correct it. And I've been doing this like with my eyes closed, so I'm sorry, I'm blanking on the terms because I'm just so used to doing it. I'm trying to keep it not so scientific, but they'll correct that so that when you look at the rate, yours, the level, yours is correct based on their range. That's what we mean by the differences depending on the lab. And then
Okay.
Yeah,
second,
that's helpful.
okay, thank you. Sister, I'm trying to sometimes, I was always a chemistry major. This is like, it was kind of like, okay, I need to write for the reader and not for me. Like, I want to make sure that I'm not like making this too just convoluted. So thank y'all for confirming that I'm not missing the mark on that. So for the next one, like we said, if you see the main thyroid test and then it looks abnormal, your doctor can then order additional testing, more detailed testing, and that's where your free T4 and free T3 are going to be measured. Okay. And specifically for our thyroid, there's so many things that this affects, and especially in us as women, our hair, skin, there's just our weight. There's so many areas that this can affect. And also sometimes this abnormal hormones can also be an indicator of cancer, right? So, and there's other diseases, Graves' disease, I'm sorry, not Graves' disease, Hashimoto's disease is usually one as far as the thyroid is concerned. So, again, this is an example of the initial test is done, and then you've got further testing. This is just in layman's terms, just to be able to go over what this means to, as you said, Jeff, to be able to think, okay, well, what is the next question I should ask? This is basic. Then the next level, I should ask for this, right? Maybe I need to know what that means, or I should expect follow-up or additional testing after this first set of tests. So that's a good call out, but we can't tell you definitively on this, as Lisa said.
And this is Cynthia. You can ask some basic just question. And the basic question, well, what does it mean to have an overactive thyroid, right? That's just a basic question to ask. And what disease is associated with that? That's the questions that we can keep it legal. And you can ask your doctor.
Yep.
Thank you. Okay, so I know we're getting close to time, so I'm not going to run through this, but just to call out that urinalysis, as I said earlier, is a dipstick, is maybe a first pass, and some of those things can be looked at using a dipstick, and depending on what those levels look like, your doctor may order more detailed testing from blood. All right. Also, with your urinalysis, when you give that sample, there is a visual inspection done that can also tell them some things about it. And so they usually jot down what that appearance is, smell, color, and those kinds of things as a part of the collection, so that all of that can be reviewed as well. Okay.
Great.
Next slide. And of course, urine drug screens can also be done with a dipstick. And this is just some of the ones. And I'd like to call out, it's not just about, oh, you're getting a job and you got to do a drug screen, but there are instances where your doctor wants to see, have you been taking certain things in before they do procedures or what have you. So this is another reason that they may do a quick little dipstick just to see this, right? And that's prescription drugs as well. There are certain things that, you shouldn't be taking, even if you have a prescription, and they can do a quick little spot check with some of these. All right, next slide. Oh, there we go. So thank you. I've jotted down a couple things, and that we may be able to provide some content later on. But yeah, that was what we wanted to cover today.
Thank you, Marshika, and that was great. And
thank you.
And we made it through part 1, and what part 2 will be created to do is, if there are some abnormal lab results that may result in diagnostic tests that follow, sort of what you shared, Japs, in this instance, that you may need to do additional things to look for certain things. We're going to make an attempt next week to show that correlation between some lab results, more common things that will correlate to other diagnostic tests that need to be done. So stay tuned for that. But before we move on, I saw in the chat that we had from the Posey line that there was an update following what Cynthia said, that with that family history, there should be, with appropriate history, baseline lipoprotein A should be checked. And that's what's put on there. And so this on the lab test, it's going to look like the LPA. Thank you, Dr. Posey, for putting that in there. And if there are specific diagnostic tests or lab results that you want more information about, now is the time to put it in the chat so that in part 2, we'll have an opportunity to address some of that, to be able to bring that to your to everyone's attention, not talk about your diagnosis per se, but if there, concerns like what could be seen with the CEA, what could be seen with the ALT, like you talked about liver disease, but what are some common things that people may have, or if there's pancreatitis, if there's other stuff that's out there that we need to talk about and address. We hope that this was a beginning of better understanding, but we think we can answer your questions after this by your knowing what your lab results are, and if you have questions about specific things. That's why we're here. What is it addressing? What is it looking for? Not the diagnosis, but what they may be looking for and what you're concerned about. So again, Marshika, we thank you for sharing that and giving us that update. And if you have questions, please, anybody. We want, are there risks? Okay.
So I put something in the chat that, Lisa, I think is really important as we have arthritis, is, crippling our elderly people. What tests are really important for arthritis, right?
Okay.
Millions of people have arthritis, but there are certain tests that we can do. Like some people have autoimmune, but I think that's really important because arthritis can be debilitating.
Okay.
But there are some tests that we can do for that.
Okay, good. All right, I'm
Lisa?
looking at the chat. Okay. All
That was
right.
essentially my question.
Yes, Teresa, I see that. Okay. All right. And you want to know how to interpret them. And from our standpoint, the interpretation becomes what are good and effective questions for follow-up for you.
Correct.
And how to do that. Yeah.
What test I should be asking for, and how do I interpret that to get to a better place
Okay.
in the
All
treatment?
right. Okay. And then here's one risk in doing the nuclear test.
And Lisa, that was, I think it was Jabs who said that you took the pill and waited 4 hours, and I guess that got into your system. And I know there's another nuclear test where they actually put stuff into your veins so that, when you're doing some kind of a scan. So that's what I had in mind.
Oh, okay. I don't know.
That should be a part of your diagnostic bit, right?
Yeah, I don't know.
Okay.
We see it as a question, may not be able to answer it tonight, but that's why it's an ongoing conversation.
Yeah.
Okay. There you go, Mark. There, if you don't feel like an expert after this brief engagement, remember your medical team owes you an explanation. Ask your doctor to explain. And yes, you with the disclaimer, this is basic information. We take our information from places like Healthline, from Everyday Health, or other public sources that we vet. So yes, she will send a copy of the slides out to our mailing list, and it will be a part of the resources we have after. Okay. So and feel free. Okay. All right. Thank you everyone for joining tonight. This was great. Appreciate you. Stay tuned for part 2.
Thank
you.
Thank
We're
Thank
you.
you
going to
all.
continue to support, empower, and make sure everybody's in a good place. Again, Marshika, thank you for that very clear understanding and review of lab results.
Absolutely. Thank you all for
Absolutely.
having me.
Thank you.
Appreciate it.
Thank
Okay.
you.
All right.
Thank you all. Good night.
Thank you.
Good night.
Thank you.
Bye-bye.
Thank you. Good night.